Dear colleagues and friends, my task is to talk about the relationship between endocranial hypertension and ultrasonographic diagnostics of the retrobulbar region of the optic nerve. In adult, the skull is a non-expandable structure and contains brain, blood, and cerebrospinal fluid. The total intracranial fluids are cerebrospinal flow, 10%, blood, 10%, and then remaining 80% are intracellular fluid and interstitial fluid, respectively 68% and 12%. Allow me to spend some time to talk about the CSF that, in my opinion, plays a particular role in the establishment of the endocranial hypertension. The CSF is contained in the brain ventricles, the cerebral and spinal subarachnoidal cisterns, and subarachnoidal spaces. It is produced mainly by the choroid plexus, but intracellular fluid and interstitial bulk flow certainly account for a portion of it. CSF is absorbed across the arachnoid villi into the venous circulation, and a significant amount probably also flows into lymphatic vessels within the dura mater around the cranial cavity and the spinal canal. The absorption rate correlates with the CSF pressure. CSF is renewed about 4 times every 24 hours, and reduction of its turnover rate during aging leads to accumulation of catabolites in the brain and CSF that are also observed in certain neurodegenerative disease. The CSF space is a dynamic pressure system. The CSF pressure determines intracranial pressure, with physiological values ranging between 10 and 15 millimeters in adults. Apart from its function of hydromechanical protection of the central nervous system, CSF also plays a prominent role in brain development and regulation of brain interstitial fluid homeostasis, which influences neuronal functioning. CSF circulation from site of secretion to site of absorption largely depends on the arterial pulse wave. Additional factors such as respiratory waves, the subject's posture, jugular vein pressure, and physical effort, also as well as microgravity condition and eye mount and permanence, modulate CSF flow dynamics and pressure. Cranial and spinal arachnoid villi have been considered for a long time to be the predominant sites of CSF absorption into the venous outflow system. Experimental data suggest that cranial and spinal nerve sheaths, the cribriform plate, and the adventitia of the cerebral arteries constitute substantial pathways of CSF drainage into the lymphatic outflow system. Let's now focus on the third cranial nerve that leaves the chiasmatic cisterns to enter the eye orbit and the ophthalmic bulb enveloped in the meningeal sheaths. Using this old but very clear drawing, we see the third cranial nerve that may be divided in 4 segments. But it is surrounded by the meninges, the dura, the arachnoid, and the pia mater. The 4 segments are the intracranial cisternal segment, the intracanalicular segment, the infraorbital segment, and last the intraocular segment. Inside the meninges, dura mater, arachnoid, and pia, we found also the subarachnoid space, where CSF flows. This is one of the studies confirming that at the level of the proximal part of the infraorbital segment, at 3 mm from the retina, we find maximum distensibility of the subarachnoid space owing to the non-uniform distribution of the subarachnoid trabecular fibers between nerve and sheaths. Let's now focus on the relationship between the ONSD and endocrinal hypertension, whether secondary to space-occupying processes or idiopathic. But we must not forget those conditions that alter the physiological variations in the brain-eye pressure gradient due to peculiar environmental conditions of long duration, such microgravity conditions and excursions in high mountains. The pressure-volume relationship between intracranial pressure, volume of CSF, blood and brain tissue, and cerebral perfusion pressure is known as the Morrow-Kelly hypothesis, which states that the cranial compartment is incomprehensible and that any increase in volume of one of the cranial constituents must be compensated by a decrease in volume of another. Intracranial hypertension leads to nervous structure compression and dislocation, the midline shift and infratentorial herniation. CSF dislocation, changes of production and reabsorption of it, and blood flow reduction. But what happened at the retrobulbar portion of the optic nerve that we can study by means of ultrasound? There is an optic nerve sheath diameter dilation and an optic disc swelling. And this is how we can measure these modifications. Considering the nature of the insonated structures, we easily understand the B-mode image that permits us to know that we are in front of the nerve, the optic nerve, with the sheaths. In this little movie, short movie, we see the end of or the beginning of the optic nerve with the sheaths. And this is insonated by an transverse approach with a linear probe of 10 megahertz, but we can use smaller probes like this microconvex probe, and which permit us to have different approaches. This is a transverse approach. Here we see that it's not so easy to well recognize the structures because of the tortuosity of the nerve, and you have to remember the tortuosity of the nerve is one of what happens when things that happens when there is intracranial pressure is elevated. And in the other approach, we will see better the dimension of the nerve and the retina and lamina cribrosa and nerve and the sheaths. So it's easy to understand that we are in front of the meningeal sheaths here, and this is the retrobulbar fat. And this is how we have to measure it. From the retina, we point the 3 millimeter, and perpendicularly to this line, we point the measurement of the transverse diameter of the optical nerve sheath diameter. It's the same thing with the microconvex probe we saw before in the two kinds of determination. Okay. In this paper, the authors investigated the relationship between the subdural pressure and the OS and D diameter, and in this figure we see the increase of the diameter as pressure increases. Reproducibility and accuracy of the optic nerve sheath diameter assessed using ultrasound compared to magnetic resonance imaging. This is the title of this paper, and the conclusion are that this kind of tool have a good reproducibility, measurement accuracy, and agreement inter-observer inter-observer. This is the cutoff limit between normal and pathological conditions, but we can find other kind of measures. This is a smaller one in this Korean study, and so there is a variability of cutoff in the literature. If we add to this examination the measure of the optic disc swelling, here we see the papilla and the margin of superior of the papilla and the height of the papilla, where it's better the visualization of it, and this is where we see better the limits of the papilla. We can measure it and have some indication. Also in this measurement there is a wide, relatively wide cutoff, and if we consider 6 millimeter, we have a good sensitivity and a low specificity, relatively low specificity. But if we think about a threshold value of 1 millimeter, the specificity we see is much higher. So in conclusion, the quantification at 3 millimeters behind papilla and the ODS are easy and safe and can be performed with good reproducibility, measurement accuracy, inter-observer agreement, and is quite good for longitudinal studies. We have to keep in mind that there is a cutoff limit that is not established for all wide, because there is age variability, ethnic variability, equipment dependency. But if we consider to do this examination together, this tool gives us a very useful tool for making the diagnosis of intracranial hypertension. Thank you for your kind attention, and goodbye.